Good evening. So this evening I'm going to be talking about stroke. And stroke is a disease which depresses a lot of people, and there are a lot of myths around it. So this is a great opportunity, I think, to talk about the really positive sides of what's been happening in stroke over the last 10 years, but also some of the challenges that are going to face us both individually and as a society because of stroke over the next few decades. It's very apt that this is being done in Gresham College. So Thomas Gresham was obviously a great financier, a great patriot, the benefactor who set up this college, but also a stroke victim. He died at around the age of 60, and this description, coming from the exchange to his house, he suddenly fell down in his kitchen and being taken up was found speechless and presently dead, is actually a very good description of a severe stroke leading to someone dying. He was, however, unlucky. In his period of time, stroke was actually an extremely rare cause of death. Now, there aren't equivalent data for exactly when Sir Thomas himself died, so I've gone to a slightly later stage, but where the death rates would have been roughly equivalent. And these are the deaths in London in 1634. And this was not a plague year. That's an important point to make. If it was a plague year, plague would dominate all other causes. And if you look at all the causes, and these had to be recorded by every parish clerk in London, it was an extraordinary piece of early public health information. What you found is of around 11,000 deaths in that year, apoplexy, which is the old name for stroke, and migraine, which sometimes was stroke, was 35 deaths. Around 0.3% of all the deaths were there, whereas various forms of infection, fever, consumption, it's an old name for TB in the main, smallpox, massively dwarfed that. So in Sir Thomas's period, to die of stroke was a demonstration of the fact you hadn't died at an earlier age of various infections. It was a very rare disease indeed. Whereas now in the UK, stroke, and this is past its peak, causes 7% of all deaths and is the fourth leading cause of mortality. So very substantial change. Now in wealthier countries, stroke is now slowly but steadily retreating. And most of this talk I'm going to be talking about that and why that is happening. And in this talk I'm going to really go across 5 main areas and then just a few forward looks at the end. The epidemiology and trends of stroke in the UK as an example of a developed country. The effects of stroke on different parts of the brain. And I think this is critical because I think people think of stroke as one thing. It is not. It is many different things. The prevention, both primary and secondary, and I'll explain that when we get there. Treatment, which is currently in its infancy, but is substantially better than it was when I first started in medicine. And then living with stroke, including living with people who've had a stroke. This is part of a series on health at the extremes of life, and the reason it fits in that is stroke is essentially a disease of old age. Some people get stroke earlier on, but essentially it is a disease of old age, and the risk of stroke doubles every decade after the age of 55. So that in the UK, by the age of 75, at this point in time, and it's getting better, roughly 1 in 5 women and 1 in 6 men will have had a stroke. So these are quite substantial numbers. But, and it's important to say this, many of these strokes are relatively mild. I've illustrated this with some very famous people from who were the leaders in the Second World War era. Sir Winston Churchill, holding in his hand one of his major risk factors for stroke, in fact, he had 2 strokes during his premierships or during his active political life, the second of which significantly disabled him, but the first one really didn't. He was very effective after his first stroke. Eisenhower, who had a stroke and continued as an effective president for some time afterwards, dying of unrelated causes later. But then on the other side, their partners in the Second World War, Stalin, who died of a stroke, and Roosevelt, who died of the related complication of cerebral hemorrhage. So this was an extremely common thing, and the point I'm making is it's common. It can affect people, including in the wealthiest and most highest socioeconomic status people, but in many cases people can continue to have highly productive lives afterwards. Now, if you look at the data from the UK for circulatory disease, so this is combining stroke and heart disease, and that's because their risk factors are basically the same, broadly. The people I've just talked about all died at about the peak time for stroke in the UK, at a point when men by far outweighed women in terms of the number of strokes they had. And since that peak in the late 60s and early 70s, stroke has steadily decreased, and the difference between men and women has gradually but very, very substantially narrowed. And the reason for that is largely around reductions in smoking. There are many other things I'll come on to, but the big difference, in particular difference between men and women, can largely be explained by that. And these are the data taking slightly over the last few decades in the 4 countries that make up the United Kingdom. And as you can see in all of them, stroke has been on a steady downward path, and there is no evidence that this downward path is flattening out. So I anticipate this will continue to improve over the lifetimes of everybody in this audience. And if you look at this graph, and I've highlighted in red because it may not be obvious from the back of the hall, cerebrovascular diseases, this is in women. The exact numbers are slightly different between men and women, but women are a good illustration. The pale blue bar is the proportion of disease in 2003, and the dark blue is a proportion of disease in 2013, a decade later. And as you can see, stroke has substantially decreased over that time. So this is really very good news. But there is a paradox in this, and this is where I think, and I'll come on to this again at the end of the talk, this is where the public issues are going to come in with stroke. The stroke incidence rates, that is the number of new strokes every year, are steadily going down. That's fantastic news. Secondly, the mortality rates, the number of people who, once they've had a stroke, die from it, are also going down every year. But what that means is the number of people who are surviving a stroke is actually going up, which is good for them, very clearly, and good for their families and good for society. But they are going up, and the population is aging. And if you add those two together, the total number of strokes in the UK, in the sense of people surviving after a stroke, is steadily increasing and will continue to increase. So you've got this paradox that the incidence of stroke, new strokes, are going down all through our lifetimes, but the number of strokes in terms of people who are living with a stroke at any one time in the UK are steadily going up. And they are not spread evenly through the population. So this is a map of London, and what you see is the very pale colours are where the number of people with strokes is very small, and the dark colours are where strokes are very common. And some of you may have gone to a talk I gave on demography earlier on in this series, and what that showed is that young people live in the centre of cities, and as they grow older they gradually move out, and once they have 2 children they move right out of cities. So what we're seeing is actually simply a reflection of the demography of London. Where there are young people, you don't have many people surviving a stroke. The further out you go, the more people you'll have. And the reason this is important is there are some areas of the UK which fairly soon will have over half the population over 65. And this is where the number of people living with stroke is going to concentrate. Of course, stroke doesn't only happen in elderly people, it can also happen in younger people. But the striking thing about stroke, in contrast to many other diseases including heart disease, is stroke in the elderly, there is a relatively small gradient between the most deprived and the least deprived. These are data from Scotland, but they could be equally be from England or Wales. The dark blue bars are strokes in people over the age of 65, from the most deprived on the left to the least deprived on the right, as you look at this. And as you can see, there's a relatively small gradient for strokes over the age of 65, but the green bars are strokes under the age of 65, and there's a huge gradient. Most people who have strokes under the age of 65 come from poorer areas of Britain and poorer parts of society. Now, historically, the medical profession, I would say, was not terribly good with stroke. Now we've got to describing it. Apoplexy, essentially a proxy for stroke, was described by Hippocrates and probably earlier, and it's a relatively easy thing to diagnose. And by 1658, the first reasonably serious scientific suggestion that stroke was caused by problems with circulation had been made by Johann Jakob Wepfer. But really between that time and about the 1950s, remarkably little progress in actual treatment. So really quite a long delay. And in fact, you can find quite standard textbooks of medicine from the early 20th century suggesting the bloodletting, which I have to say would be a big mistake in stroke, is a sensible thing to do at the early part of the century. And I think medical nihilism, doctors just thinking nothing could be done, this is devastating and it's going to be pretty horrible, and basically just say to people bad luck, dominated thinking until relatively recently. Arguably, in my view, really until the late 80s. There was, however, one bit of very important science that was done earlier and which explains quite a lot of what I'm going to go on to talk about when I talk about different sorts of stroke. And that was work done on the anatomy of the circulation of the brain. And probably the most famous contribution to this was Thomas Willis, FRS. He described what is still called the circle of Willis, the arrangement of arteries in the base of the brain, which essentially is the basis for understanding why different strokes cause different patterns of disease. Now, Thomas Willis was meeting in the Royal Society at the point the Royal Society was actually based in Gresham College, and in fact many of the illustrations from his early neurological work were done by that polymath Sir Christopher Wren, former professor of this college. So I think we can claim at least some ownership of this bit of very important early science. When you think about strokes, they are all caused by a problem with the circulation of the blood to the brain, with a bit of the brain being starved of oxygen for long enough to be stunned and then to die. That basically is what a stroke is. And two things can do this. The first, and by far the most common, at least in the UK, 85% of strokes, is what's called an ischemic stroke. That basically means where there is a blockage caused by a clot that blocks off the artery, meaning the blood supply doesn't flow, and therefore oxygen doesn't get to the brain, and the cells in the brain, which are really active, die. They need oxygen the whole time because they're extremely active. In a small but important minority of cases, stroke is caused by hemorrhage, where you actually get a bleed in the brain. And the fact that this happens is important for reasons I'll come on to, because it means that we have to be able to scan people's brains before we can treat them. Because if you try to deal with this by breaking up clots with clot-busting drugs and what people have got is a bleed, you can actually kill them. So this is an important differentiation. And what has allowed us to advance on stroke is that we now have much better images of the brain. So until we got two advances in physics, first CT scans, and a CT scan you can see here with the stroke up in this area. You have to be quite well trained, I think, to see these kinds of stroke, or an MRI scan where you've got a stroke that I think is fairly obvious in this scan. Once we had these, it was possible to associate what happened to people clinically and what actually happens in terms of their brain pathology. And we actually had a much better understanding of what we then should do about stroke. So a big breakthrough was in the diagnosis that was made possible by CT and MRI scanning. And we've now got really very sophisticated methods for visualizing the blood vessels of the brain. This is an MRA. It's an MRI scanner, but with using a slightly different methodology. And a really beautiful picture of the blood vessels in the brain. This is one where some dye has been squirted into an artery, and then you take photographs of the brain with the dye in the artery, radiopaque dye, again giving really beautiful pictures, and here showing a narrowing and blockage. And these are much more sophisticated on the right, things looking at small vessel blood flow in the brain. So we now have really sophisticated ways of looking at the circulation in the brain, which help us to make practical decisions. So imaging has been critical to actually being able to do things in stroke. Now, the bit of stroke which I think is often not understood is most people think of stroke as a catastrophic event that leads to people having weakness down one side. That, I think, is very much the popular picture of stroke, and certainly that does happen. And the thing with the brain is it's wired slightly counterintuitively so that the left side of the brain controls the right side of the body and vice versa. And on both sides of the brain, you have a strip of the brain which is the motor area, which actually controls your voluntary movement, and a strip of the brain which is your sensory area, which roughly mirrors that, which actually has the sensation. But not all bits of the body are equally represented in the brain, because different bits of the body require hugely more computing power to make them do what you want. And the two bits that dominate, and this is a cartogram of what it looks like on the brain, are a very large amount of the body is given over to the face. The brain is given over to the face because it's a very, very complicated mechanism, and a very large amount is given over to the hand. So in general, most strokes will affect one or other of those because they're just so large. Other areas are much smaller. So if you have a stroke that affects this area of the brain, and this will usually be a middle cerebral stroke, then what you tend to get is weakness, and you may get some change in sensation. But within the brain, and I'm just not going through inevitably, exhaustively, within the brain there are multiple specialized areas. And one of them, two of them, in fact, are around speech. And these, at least in right-handed people, are on the left side of the brain. If people are left-handed, it can be either side. And what you have is an area at the back of the brain, near this bit of the brain which processes sound, called Wernicke's area, and an area in the front of the brain. Now, if you get a stroke in the area up here, which is the receptive area, then someone can speak completely fluently, but what you get out is jumbled up and can be nonsense. So they have the ability to speak, but they don't have the ability to comprehend or to process the way they're thinking about their speech. If you have a speech in this area, in the more motor area, they can understand speech, they can read perfectly well, but they have real difficulty in finding the words they need to express themselves. Now, this is an example of the highly specialized nature of the brain. So if you have a stroke in one area, you can have a very big difference from a stroke in another area. And then a third area, which kind of various bits of the brain can affect this, is the bits that actually control the way you speak, control your tongue, control your palate. And then people can understand, they can find the words, but they have real difficulty moving their mouths to actually say those words. It's called dysarthria. If you have a stroke on the other side, a whole set of very different and often rather complicated things happen. People, for example, have an ability to recognize faces from a stroke on this side. They get neglect. And so this is, for example, is a clock as drawn by someone who's had a stroke on that side of the brain, on the right side of the brain. And they can actually look at their hand and think it's someone else's hand, or just completely neglect it. They shave one side of their face but not the other. They eat one side of a plate but not the other. It's not they can't see, but they cannot concentrate on the side. Their perception of distance and space goes, and they can have changes in concentration and memory. Then there's an area of the brain which is supplied by the back, by the posterior, so-called posterior circulation, and that controls, again, very different areas. If they have a stroke on one side at the right at the back of the brain here, furthest away from the eyes, that's where the processing of vision happens. So what they get is they lose the ability to see on the other side of the visual spectrum. If they have a stroke here in the cerebellum, this is bulging out, then they become very unsteady in the way they walk and slurred in the way they speak. It's a bit like someone who's drunk, actually, and they lose coordination. And if they have a stroke down here in the brainstem, they can have very serious problems because a whole lot of traffic goes through this. I'll come back to that. The point with all of these, however, is that the area that's affected by the stroke is affected very discreetly and may be affected very badly, but all the other bits of the brain are unaffected. So someone may not be able to speak, but every other bit of their intelligence, every other bit of their function remains as it was. They are the same person. This is a contrast to what I'll be talking about next time I'm here about dementia, where it's a lot more complicated. Most of the brain is unaffected by someone who has a stroke and survives. Recovery depends obviously on how big the stroke is. In a huge stroke is going to be a very serious issue. It depends in part on the cause. So a haemorrhagic stroke, a bleeding stroke, is more severe. And I'll come on to, if you've got a stroke from a clot from the heart, that often is more severe. And it also depends on the site. Some bits of the brain are better at relearning after a stroke. It's not that the brain regrows, but other bits of the brain relearn around it. Other bits, particularly, for example, the brainstem, have real difficulty. So it's very difficult to predict when someone has a stroke how well they're going to do. It varies enormously between different people, but depends on size, cause, and site. So that's a bit about how strokes are. Moving on to prevention. Now, there's primary prevention. Primary prevention in all public health is when you stop a problem before it's even occurred. You know someone's got a risk and you stop it before the thing has occurred. Then there's secondary prevention, which is where they've had, let's say, a small stroke, and you say, right, this person is really at high risk, I'm going to stop further ones. That's secondary prevention. And then obviously treatment. And primary prevention can be based on population level changes and individual level changes. That's just the framework I'm going to discuss the next section on. The easiest one, not easy for those who smoke, but the easiest one in a sort of intellectually is smoking. Smokers are 3 times, sorry about the cough, smokers are 3 times as likely to have a stroke as non-smokers. But that risk decreases quite rapidly after someone stops smoking. So stopping smoking at any age in life is an extremely sensible thing to do. And one of the reasons why stroke has gone down so rapidly in the UK is because there is a very substantial reduction in smoking in every age group over the last decades. This is a phenomenal public health achievement. The second one, which I think most people are aware of, is blood pressure. And broadly, until you get to a blood pressure where you're in actual shock, broadly, the further down your blood pressure goes, the lower your risk of stroke. And stroke is down here in the red dotted lines. So what you've got is a reduction in the blood pressure in 10 millimeter of mercury things, for those who get their blood pressure measured by their family physician, their GP. And this is the reduction you see. And if you get it right down by 30 millimeters of mercury, you're basically, if you model it out, reducing their risk of stroke by over 70%. Very, very substantial reduction. So blood pressure reduction, very, very major protective measure. Now, you can reduce blood pressure broadly in 3 ways. One of which is personal things like exercise. We'll come on to that. The second are population level things. And one I'm going to highlight, although there are others, is salt. Broadly, the more salt you eat, the higher your blood pressure, and therefore the more likely you are to have a stroke. But the great majority of the salt that you eat, you're not aware you're eating. You don't put it on your food. It's in the food you buy. It's in ready-made meals, it's in canteen meals, it's in your bread, it's in your soup. It's there already. You're not given a choice. If you want to eat and eat the things which have nice pictures on the front, you're going to get a load of salt. Now, there has been an agreement with the food industry which has led to a gradual reduction in salt in the UK over the last decade. I think this has got a long way to go, but one of the things we can do is gradually, not suddenly stop people eating salt, but gradually ease it down so people are less used to very, very salty dishes. And actually, if you went back, if you could turn the clock back 30 years and eat standard meals then, you would find they are a lot saltier than they are now. But because it's gone down gradually, people don't object to that. In fact, now you probably find salty meals as they were now a little bit unpleasant. Then doctors have a role to play, and what they can do is they can actually find that someone's got blood pressure in screening by a number of different methods and give them drugs. Now, I'm not going to go through these drugs in detail. I did that in the last talk I gave, so people are interested in a bit more of the science behind these drugs, then I would recommend my previous talk, which I think goes through it reasonably thoroughly. But I'm just going to highlight 3 classes of drugs which are important for reducing blood pressure. Beta blockers. And I'm doing this because many people in the audience will be on one or more of these drugs. Beta blockers essentially counteract the action of adrenaline, the thing which allows you to fight and flight, but also raises your blood pressure on the heart and smooth muscle. So it blocks the effects of adrenaline on particular tissues. The second are what's called ACE inhibitors, and they do something in a system in the kidney, has a number of different effects, which actually is deliberately designed, and it's to help you, but of course it doesn't help you when you've got a high blood pressure. If your kidney measures your blood pressure is going down, it pumps out chemicals which then push your blood pressure up again. Useful when you're young and bleeding because someone's attacked you after a woolly mammoth fight, rather less useful if you're a hypertensive man or woman with risk of a stroke in your 70s. And the third one, and this was actually originally devised from stuff coming from snake venom, so by a rather long and tortuous path. And the third of which is something which stops you reabsorbing salt, sodium, which is the key bit of salt, from the other parts of the kidney, thiazide diuretics. That's a bit of the science behind it. But when you're thinking about it as a doctor or as a person who is actually being offered an antihypertensive, what you really want is something which maximizes your chance of not having a stroke and minimizes the effect on your life in other areas. And I'm going to talk you through this only to illustrate that this is about balance of risk and benefit. So just taking these three drugs, the thiazide drugs are very, very cheap. We know they're safe because they've been used for years, and all you've got is a risk of stroke because of high blood pressure. They're excellent drugs. The major problem they have is they can precipitate gout. But most people, that's not a problem. They have a few others, but that would be the most common, I would say, in practice. Beta blockers, the ones that prevent the adrenaline rush, excellent reducing blood pressure. They also protect the heart. So they're one of the drugs that I talked about in the last talk about heart disease, and they can reduce angina. But they cause cold peripheries, they can trigger asthma in people who've got asthma, they can interfere with sport, they can interfere with sex and a variety of other things, not in everybody, but in a few people. And as a result, you probably won't want to use them unless if other things are going to do just as well. But if you've got heart disease, they're a lot better. And the ACE inhibitors, they protect the heart very well. They're very good if you've got diabetes. They're very good if you've got renal failure. They reduce cardiac failure. They've got a lot of other effects, but they have quite a significant number of side effects, particularly a very annoying cough in a lot of people, which sounds trivial until you've got it, and then it isn't. So the point I'm making here is that what you're trying to do is balance the additional benefits of the drugs against the side effects. But usually you will find a combination of drugs which work for everybody and don't cause them major interference with their lives. Then we come on to the next thing which doctors can help with, atrial fibrillation. Now, atrial fibrillation is caused when the heart, the top bit of the heart, starts to go into an odd rhythm. Now, the usual way in which the heart beats is the top bit of the heart beats, and then very shortly afterwards, the bottom bit of the heart beats, and that pump, that two-way pump, is what pumps things around the body. But most of the heavy muscle and the heavy lifting of the pumping is done by the bottom bit of the heart. In atrial fibrillation, what happens is the top bit of the heart goes mad. And instead of beating in a nice steady way, it twitches all over the place with no proper beating, and all the work is being done by the bottom bit of the heart. Now, I talked a bit about that when I was talking about heart disease in the last series of talks, and I'm not going to repeat what was said because that's not relevant to this talk. But the key point about this is it happens gradually, more commonly, as you grow older. This graph at the bottom is what happens to atrial fibrillation as you grow older, and it steadily increases with age. Often when people start having it, you can give them drugs or you can give shocks, very small shocks across the heart and flip them into an ordinary rhythm, but after a while it gets stuck in atrial fibrillation. And the problem is that because this muscle is just twitching, it's a very, very good place for little clots to form. And that is what causes stroke. Little clots forming because the blood is designed to clot as soon as it finds it's not moving. What stops it clotting is the fact it's circulating. If you can sit up here in a small pool, it'll start to cause a small clot, and then this clot will flick off, go up the arteries to the brain, hit the brain, and you get a stroke. That's the way the atrial fibrillation causes this. It's a major cause of stroke. It's very easy to diagnose. You can do it simply by feeling someone's pulse, and then you can confirm it by looking at the heart tracing, and I suspect anyone in the audience looking at this can tell that if I tell them that one's normal, they can tell that that one's abnormal. It's pretty easy to tell. It's a risk of stroke. Your risk of stroke, if you get atrial fibrillation and are not treated, increases 5 times compared to the day before you had that atrial fibrillation. It's a very substantial increase. And yet, around 30% of people in the UK are not on treatment. And unfortunately, these 30% are not distributed randomly. There are some practices here in the City of London which have 99% of all the people with atrial fibrillation on treatment, well, certainly in the 90s, and there are some practices which have less than 30, well less than 30. That's a very serious problem. If adequately treated from atrial fibrillation, in England alone, we could probably prevent around 7,000 strokes a year and save around 2,000 lives. It's quite a substantial gain, that. And the way we treat it is very straightforward. We use drugs which reduce clotting in the blood a bit. Not enough that you're having catastrophic bleeding everywhere, but enough to prevent these clots from forming. The drug we have been using until now, and it still remains a very good drug, still the mainstay of treatment, is a drug called warfarin, which many people know also from rat poison, but we're using it in relatively much smaller amounts, I want to reassure you. If you use this at the right amount, it reduces the risk of stroke in someone who's got atrial fibrillation by 2/3. A really substantial reduction. Really worth having. Its disadvantage is that warfarin, you have to take your blood regularly because your clotting levels go up and down the whole time. If they go down too low, then actually you run a risk of stroke, and if they go too high, you run the risk of bleeding. So your people have to go to clinics repeatedly. So a big advantage in the last few years is new anticoagulations, anticoagulant drugs, so-called NOACs. There's a lot of them now, and they're probably at least as good as warfarin, at least some of them, and once you're on them, you don't need to go to the clinic. You can just take them, and you can take them for the rest of your life. So this is a substantial advance, and this is going to be a big shift, I think, over the next 10 years. Then cholesterol. It's very clear that reducing cholesterol reduces the risk of stroke, and you can do this by many different ways. Diet, improving your exercise, a variety of other things. But of course, doctors can help as well by giving statin drugs. Again, I'm sure some people in the audience are on those. And if you have a fairly high risk of a cardiovascular event, and that's fairly easy to work out a score for everybody on that, largely depending on age, it reduces your risk of stroke, irrespective of anything else, by 25%. Very substantial difference. Now, part of the problem with statins is, for a variety of slightly complicated reasons, they've become a considerable punch bowl of all in the media, including the UK. For some reason, I've never understood the Daily Express and the Sunday Express are at permanent war with one another as to whether statins are a good thing or a bad thing. Both of this one here is almost right, the top one. And I think there are risks to statins, but they're relatively modest if you're at high risk of stroke, because stroke is a very serious condition. It's worth taking some risks for. And finally, in a sense, exercise and drugs, basically drugs, rock and roll, and all the rest. Starting off at the top risk, I'm sure a Gresham College audience doesn't take much cocaine, but there are people who work within a mile of here, allegedly, and take cocaine, and they increase their risk of stroke by 700% in the 24 hours after they take it. I recommend you don't. Being overweight and in particularly being obese significantly increases your risk of stroke, but moderate exercise, again, you can reduce by a quarter stroke by having exercise, and exercise does not have to mean running around in lycra. It can mean having fun, as being demonstrated by this fantastic couple on the right. And alcohol in excess does increase your risk of stroke, probably largely because it pushes up your blood pressure. So it's basically an indirect effect of that on the blood pressure. Once you get to the point where you've had you move from a situation where you've had no stroke to one where you've had a stroke, then the numbers change quite a lot. And the big warning is something called a transient ischemic attack, TIA, which is also known as a mini stroke. It is a sort of a stroke, but it vanishes very quickly, often after a few minutes, certainly within 24 hours. Once it's gone beyond 24 hours, it's no longer, by definition, a transient ischemic attack. And it's usually caused by a clot that hits the brain but breaks down before it causes damage. So you get a temporary stroke because it's starved of oxygen, then the clot breaks down because of the natural mechanisms in the blood, and then the oxygen comes back to the brain and the brain recovers again, because there's a period of brain stun before the cells actually die. It's a serious warning. If anybody sees someone who has this, this is a very serious warning sign, because untreated, 40% of people who have one of these will go on to have a stroke, most of them within a few days to weeks. So the risk is very heavily front-loaded. You immediately move from primary to secondary prevention. You've shown you're someone who is at risk of stroke, and therefore even things that you might have thought I'm not going to do before, like having drugs for blood pressure, having statins, it's a kind of no-brainer. You want to do it. If you see someone who's had a transient ischemic attack, if you have one yourself, and in the audience some people will have them, first thing to do is take aspirin if you're not already on it, because that is clearly demonstrated to reduce your risk initially, but that's only as a prelude to getting yourself urgently to a doctor who can then start to look for the causes and reduce them. And remember the numbers I was talking about: 65% reduction, 75% reduction, 25% reduction. There are a lot of things we can do significantly to reduce the risk of stroke. And also, if you're going to go on to develop a stroke, early treatment reduces the risk of stroke very substantially. In addition to the things people have, if you have one of these or you have a small stroke, doctors will do what I've talked about before. They'll measure your blood pressure, they'll look for atrial fibrillation, they'll look, are there any problems in the heart? The one thing they will also do in addition is they will look at the blood vessels that lead up to the brain, particularly the carotid artery. This is a angiogram, so that's dye squirted into a carotid artery where you can look for narrowings up it, and this is what's called Doppler. This is something which came indirectly from the Doppler shift you see in astronomy, plus a bit of what's done with radar moving on to ultrasound. And what you can see is flow, and this very bright area here is a narrowing of the artery, and you get very, very high flow through that narrowing. If someone's got one of these, and if they've had a small stroke or a TIA, then you can do something about it. And this is where the surgeons come in, surgeons and the radiologists. So if you've got a narrowing of the artery and you've had one of these small things, and it's between 70 and 99%, then surgeons make a small incision in the neck, and they basically pull out the fatty plaque which is causing this narrowing. Now, there is a small but real risk of this thing causing a stroke itself, roughly 5%. But once they've done that, it reduces the risk from that thing in your neck that is a risk for the rest of your life, almost back to what it was before in terms of this risk. So it's definitely something that needs to be considered and tested for. And so it can significantly reduce your risk of subsequent stroke if this is your risk factor. So reduce your blood pressure, stop smoking, reduce your cholesterol, treat atrial fibrillation, and if you've got a narrowing of the neck, do this. This massively reduces your risk of having a stroke. A possible alternative, less widely used at the moment, is stenting, where a radiologist puts a balloon with a wire mesh up into the neck, rather like they do with heart disease, across the narrowing, inflates the balloon, and that holds the neck artery open. This is less widely used, but there is an alternative to doing surgery. So these are physical manoeuvres you can do to get around the blockage. And then treatment. If you have an ischemic stroke, the clot stroke, and remember 85% of people do, and you get it very early, then you can give, just as with heart attacks, you can give drugs which actually break down the clots in the brain, what so-called thrombolysis drugs. It has to be very quick, and it has to be very quick basically because brain cells die fast. After a while, you're going to get relatively little advantage, and also the risk of bleeding after it increases. And there is a risk of bleeding with it, but significantly outweighed, if you get the right people, by the advantages of saving brain cells, because you break down the clot before further damage occurs. Around 15% of people who have strokes, when they get to hospital, are actually eligible for this. But remember, the clock is ticking. So if someone has a stroke, getting them to hospital very quickly can save their life or save their brain. Very important thing to do. And finally, in terms of treatment, we've moved very much away from just a single general physician doing stroke to a situation where you have a team, dietary people, physiotherapists, speech therapists, people who specialise in a whole range of things. And this is really one of the things that has led to much better outcomes for stroke patients. Very clear evidence they improve both survival and your outcomes. Then there's some speculative science, and this has not yet there at this point. There is at least animal evidence that we might be able to do neural stem cells, so you inject stem cells into a brain that's had a stroke, and that might replace it. Fairly unlikely, I think, to be going to occur in the next few years, but certainly something that may happen in the future. There is some evidence if you cool brains after stroke, that actually slows down the progression, particularly if you're buying time. And there are a variety of experimental and neuroprotective drugs. But at this point, for treating stroke, thrombolysis, breaking down the clot, is really the major thing we have on offer. Because of the fact that it's so important to get people with stroke into hospital quickly, I think it's important that people are taught about stroke. And there's this worldwide, but certainly widely used in the NHS, nomenclature FAST. Face, do they have a sudden drooping of the face? Do they have sudden problems with slurring of the speech? Can they raise their arms and keep them up? Has that something suddenly changed on one side? If any of those happen, call 999. This is something, if it's not a stroke, fine. If it is a stroke, you'll be extremely thankful you've moved quickly. Now, just a couple of slides about living with people with stroke, because if you don't have a stroke, there's a very high chance that someone you know, a friend, a partner, a relative, a parent, will have a stroke. So a few things I think to remember when you're dealing with this. First is, when someone's just had a stroke, predicting what's going to happen afterwards is extraordinarily difficult, even for very experienced stroke doctors. There's usually quite rapid progress over the first 3 months in people who survive, and remember 75% of people will survive, and then slower progress up to about 6 months. After that, it slows quite a long way down, but it varies a lot by people. A really critical thing to remember is that most of the brains of people who've had a stroke are exactly the same as they were before the stroke. So almost everything they could do before the stroke, they can still do, except for the particular bit of the brain that has been affected. So, for example, someone can have slowed speech, but this doesn't in any sense suggest their intelligence has changed. They can understand exactly the same as they could, it's just their expression may be problematic. And there are things you can do which can actually help them to achieve the best possible life for themselves. For example, if they have dysarthria, that's the difficulty in being able to speak, and it could be because the tongue is paralysed, because the lips are paralysed, because the palate's paralysed. You may have to just go rather more slowly. They have perfectly good comprehension, they can understand what you're saying, they know what they want to say, it's just physically a bit more difficult for them. But on the other hand, they might have damage to the bits of the brain that actually cause an ability to understand speaking, but you can still talk to people by breaking down a complicated sentence into a simpler one. So, for example, instead of saying to Professor Cox, please raise your right hand, pat your head with your left hand, and raise your right leg, as a single sentence, you say, please raise your right hand, wait till it's happened, pat your head with your left hand, wait till that's happened, and raise your leg. Still do the same thing, you just break it down. What matters with stroke is working with what people can do rather than remembering with what they can't. And I think it's really critical to remember people can have very fulfilling professional and social lives after a stroke. There's a very wide spectrum, 75% of people survive. Some make an almost complete functional recovery. You wouldn't know they'd had a stroke. Most significant strokes will leave some incapacity, but even those can absolutely not affect people except in very narrow areas. This, for example, and he's been very public about this, so I'm not This is a very open knowledge. This is the very distinguished broadcaster Andrew Marr before having a stroke and after having a very substantial stroke. The only difference is which hand he uses to gesture with. He still does very hard-hitting interviews. So that is the outlines before I come on to just 3 or 4 slides at the end just about some issues for the future. We talked about the epidemiology and trends. Basic thing, this is going down. Excellent news. People's survival is getting better. Very good news. But the number of people surviving with stroke is going up. That's going to continue. We need to know that. The effects of stroke depend on which part of the brain it is, but the bits of the brain that are affected will be heavily affected. Every other bit of the brain is just working just fine. You can prevent it by primary prevention before you have a stroke. You absolutely can do things after you've had a small stroke, and there is some early treatment, but I think that will improve during all of our lifetimes. And living with a stroke does not mean the end of a good, happy, productive life, but it will lead to some limitations that you'll have to work around. Just a few things to think about for the future before we take some questions. The first thing is there's quite a significant genetic component to stroke, and specifically there is a very significant ethnic difference in risk of stroke. Black people, people of African heritage, are twice as likely to have a stroke and at a younger age than white people, all other things being equal. South Asian people, people from the Indian subcontinent for example, also have strokes at a significantly younger age than white people. That just is a fact of genes, it's a fact of some other things as well. And that is for a number of reasons, including the tendency to more hypertension, more diabetes, in African origin people, sickle cell disease, HIV in Africa. Now this is important for 2 reasons. If you look at people with young strokes in the UK, they are disproportionately people of different ethnic heritages. But if you think about the world as a whole, most of the countries in Asia and Africa are going through a rapid transition where the infectious diseases, as were dominant in the UK in Sir Thomas Gresham's time, are going right down, and people are going to start dying of cardiovascular disease. Stroke is going to be even more of a problem in these countries than it is in the UK at the moment. This is a really serious future problem for most middle-income countries. So stroke in developing countries is heading inexorably up as people live longer from infectious diseases, move to more urban and sedentary lives, and unfortunately smoking, one of the big preventable things, is actually rising rather than falling in many of these countries. This is a time bomb heading our way. Stroke costs in the UK already at this point, and this is likely to go up rather than down, stroke costs the UK, direct or indirect, between £7 and £9 billion a year. Around half of that is on health and social care costs, a variety of other things which I've written down here, which are other costs. But this is a very significant economic issue and likely to become more so. And this is not going to be evenly distributed across the UK. This is going to be concentrated in areas where there are older people. And this isn't due to drug costs. Drug costs have actually been dropping rapidly. There'll probably be a slight uptick in drug costs as we move from warfarin to the new anticoagulants for atrial fibrillation. But basically, the drugs are not what is the issue. It's the nursing care, it's all the long-term care for people that dominate this. And finally, just thinking about our population, going back to some points we discussed during a talk on demography. At the point that I qualified in medicine, very, very few areas of the UK had more than 2% of the population over 85. This is now extended across the great majority of the UK, but very, very few areas have got more than about 3% of the UK having the population over the 85. By the time you get to the point where many people here retire, this is what the map of the UK looks like, and many other developed countries will look like. Stroke is a disease of old age, and people with stroke are living longer, which is great, but therefore we can predict that the burden of stroke is substantially going to increase, and it's going to increase not in cities, because cities in the UK import youth and export age. It's going to occur everywhere else. And when you think about the social care for that, for example, in situations where the majority of people are retired, or indeed even getting people to hospitals where most people are living in semi-rural areas, this is going to present us, I think, with quite a significant public challenge. So individually, your risk of stroke, my risk of stroke, everyone's risk of stroke is steadily going down, but for society as a whole, this is a problem I think we've got to face pretty steadily and do something about. Thank you very much.